This podcast represents my opinion and the opinion of my guests. This is not medical advice, and I am not establishing a patient-physician relationship with any listener. The content here should not be taken as medical advice. Content here is for informational purposes only, and because each patient is so unique, please consult your healthcare professional for any medical questions you may have.
Welcome back, everyone, to another episode of the Not Your Doc podcast. I'm your host, Vanessa, here with producer Seth, and, of course, Mr. Not Your Doc himself, Dr. Charles Tadros.
Hey, how you doing, Vanessa? Seth, nice to see you all.
Hello.
It's awesome to be here.
Great to be here.
It is a stinking steam room outside. Like, literally, the windows are fogged because it is so hot and humid.
Somebody was looking at me funny this morning. I was walking to the building, and my readers were on the tip of my nose because I had two things in my hands, and they were fogged over. And people were looking at me like, "What? Why are you walking with readers that are fogged over?" Anyway.
It's terrible. Yay, summer, but honestly, it's just so hot and humid. And then, of course, like, your body's natural, like, cooling mechanism to sweat and for it to evaporate doesn't go anywhere. So you just get hotter and sweatier and more miserable.
Well, you just had a baby. Things are still very different for you. Yeah, but it is okay, still.
But I think everybody's hot and sweaty right now.
Sweating.
Yeah,
Everybody's sweating.
I've been wearing glasses since I was a small child. I don't remember when I actually, maybe 12 or 13, but, many years. And today was the first day I had to take them off so I could see.
Really?
I went outside.
The first time?
I went outside and couldn't see.
Goodness
have you ever came back inside and then walked up?
Sure.
Yeah. I've had that happen.
Yeah. But not the other way around.
Yeah.
There you go.
That's crazy.
That makes sense. Wow. Well, it's delightful. Anyway, so heat of the summer, an abundance of rain has caused everything growing in St. Louis to turn bright green and full of life. Like, lawns are lush and you have to mow them twice a week, and trees have all these leaves on them and flowers in bloom. So naturally, we decided the most appropriate topic to talk about today would be death and dying.
That was my idea.
Yeah.
Who's we?
Dr. Tadros was all over it. He's like, I know just the thing.
He sent us the group text. He's like, I want to talk about death. All right. You all right?
We're joking. It's a serious subject, but no, you are right. I was the one that said yesterday, let's talk about death and especially hospice.
Yeah. So what's the saying you brought up yesterday? As soon as you're born, you're preparing to die. Something cheerful like that.
That's right. Well, we're not necessarily preparing, but we're dying. Our cells are aging. But that's, yes, something like that, yeah.
Sure. Okay, so, for real, though, in all seriousness, so just as summer comes to an end and leaves start to turn brown and fall to the ground, all life on Earth has a life cycle, right, including humans. We'll all face death and experience the process of dying, and the same is true for everyone we love. All of our family members, our peers, our spouses, everyone is going to die. And I think America tends to have an obsession with vitality and youthfulness, and we're always chasing, immortality. And I think part of that is makes us really uncomfortable talking about the obvious reality. It's a way to avoid talking about the obvious reality, which is that the natural course of things is for, youth to be replaced with old age, and then life ends. So it's a fate we all meet, but we're so reticent to talk about it that most of us have no idea what to actually expect when ourselves or our loved one gets a terminal diagnosis. Yeah. I think the unknown is often worse than the reality in that case. So to face some of that today, we're going to tap into Dr. Tadros's brain and expertise again, and this time as a hospice medical director. And we're going to let him lead us in a discussion about the end of life. So how we care for the dying, how we care for caregivers of the dying, and what to expect from the process as a patient or a loved one. So,
yeah, sure.
Dr. Tadros, will you start by giving us kind of a brief overview of what hospice is, and then kind of explain why you wanted to be involved in it as a medical director?
Well, thanks for hosting. So yes, I was a hospice director for about four and a half years, several years ago, and then I changed medical facilities and group and practices, and I became a hospice director, medical director, associate medical director for a different hospice for about the last 3 years. So about 7.5 years. But whenever I was a young physician, My father went to into hospice, and I was there. It was only in hospice for about 3 days. I was there at bedside whenever he died. And my mom, about 4 or 6 years later, also was in hospice for a relatively short while, and she passed away. And when we were there, also my brothers and I. So I've had a personal experience. I've had professional experience. It was my mother also, whenever she was younger, she was a hospice volunteer. Oh. I remember that. It was important for her. So that's how I kind of got involved in hospice. And hospice is really a team. It's typically a nurse-run team. And we'll talk about that. But that's kind of a team that helps people with end-of-life patients and their loved ones, friends and family, through physical issues as somebody's dying, emotional issues, spiritual issues. But the concept of hospice was not initially about death. Back in ancient times, Latin hospice was actually for visitors and hosts, guests and hosts. So it was for people who were travelers, and this is places that were inviting.
Okay.
And then eventually, it became kind of inviting people who, towards the end of life, needed additional help. So it started actually. This is actually kind of a Western piece the way hospice is nowadays in terms of end-of-life care, and we'll come back to talking about the diagnoses and prognoses and all these things. But Dame Saunders from Britain, way back in London, back in 1948, started working with people who are terminal, and she eventually earned a medical degree. And then she came to the United States in 1963 to speak at Yale. And at Yale,
so she was a dame who decided to become a doctor?
Well, I'm sure dame was probably later.
Oh, okay.
I'm sure she was
gotcha.
given
the honorific later.
The monarchs gave her the dame prefix. Yes, but she came to talk at Yale in '63, and it kind of sparked the idea about what she was doing with her work with terminal patients with terminal diagnoses. And then she went back, and a few years later, she actually started St. Christopher's Hospice in London for the first hospice for the terminally ill in the United Kingdom. And then she taught, and not only took care of patients, but taught, and eventually the dean of the nursing school at Yale in '68 went and spent some time at it's the year after St. Christopher's Hospice, and that's how it kind of the kind of this idea of hospice spread across the ocean. And then Medicare got involved back in 1979. Started looking into it, and in '82, when I graduated from high school, it became Medicare became. Allowed this as a hospice benefit, added this as a hospice benefit. So it started really in Europe and spread to the United States, literally within my lifetime. So hospice is literally an end-of-life program that's financially supported by Medicare and other insurance plans. We use the word Medicare a lot because a lot of people are elderly, not everybody. We do have young people, children, neonates, infants, teenagers that are in hospice. We're not going to talk about those youngsters in hospice, since I've taken care of people through adult hospice for adults. But hospice is a program, but the concept is it's a multidisciplinary people, professionals, and volunteers with different backgrounds that come together to help take care of a patient and patient's needs and family's needs.
Mm-hmm. Wow. So help me, give me a little bit of context, I guess, about like Medicare. Medicare is state-run insurance for older people who are not working. It's part of Social Security.
It's not state. It's Medicaid. Yeah. Medicare is the national program.
Yes.
For generally for people with severe disabilities, they'd be born with them or acquire them, and older folk. So that's the most common primary insurance for older people, seniors in the United States. Yeah.
Sure. So like, before Medicare decided to take hospice on as a benefit and provide it as a benefit, how were people dying? How were people experiencing death?
I mean, people still obviously were dying. They probably were still dying under the care of their their kidney doctor if they're on dialysis, or oncologist, cancer doctor, or primary care doctor, cardiologist, and stuff like that. So it just wasn't as a coordinated and as comprehensive of a team back in the older days. Yeah.
Gotcha. Okay, that makes sense. So, give us some context about hospice. So, who gets it? Where do they get it? At what point in their disease progression do they get it? Can you talk about some of those things?
Yeah. So typically, people have all sorts of acute illnesses. If you break a leg or have a strep throat, the acute illnesses. Most of the people in hospice have chronic illnesses. So they're going to have typically things that are chronic that are probably not curable, and by the time that they've had it for a long time, and as problems pile up, and we'll talk about these, that they become terminal, that we don't think that we can cure them or we can improve them with the typical techniques and specializations. So now we change our purpose from trying to cure, trying to mitigate, to keeping comfortable. So we changed we don't quote unquote give up on people, but we certainly change our focus from trying to get you a heart transplant or a new valve or trying to cure your cancer, to saying, okay, the disease process is so far along. Going to the hospital and doing all these things is not what you want. It's not going to add quality of life. And so now we need a team of people to help take care of you for the last few days, weeks, months, potentially years of your life.
Gotcha. So who gets it? Someone who has a terminal diagnosis, essentially.
Yeah, the typical.
And then where do they get this care? Is it always in a hospital?
No, that's a good question. And so the care actually for these patients, and these patients, like I said, have terminal chronic diseases typically. Sometimes you have a car accident and a brain bleed, and that they can go on hospice also, so it's an acute problem. But most of the ones are like Lou Gehrig's disease, which is a neuromuscular problem, cancers, dementia, like Alzheimer's and frontal temporal lobe dementia, multi-infarct or multiple stroke dementia, heart disease like heart failure and heart disease, like coronary artery disease, HIV, liver disease like cirrhosis, emphysema, pulmonary fibrosis and pulmonary hypertension, kidney disease that are on dialysis, strokes and comas. So all these chronic big diseases that sometimes we don't have a way to get people better, certainly not to cure them.
Right. And
these patients could be in any setting. They could be in the ICU. They could be out on the general medical floors or surgical floors. They could be in the emergency rooms. They could be it could be at home. They could be in a nursing facility. They could be even in a hospice house or inpatient facilities. So there's a variety of places anywhere that a patient may be being taken care of before they enter hospice. Hospice can be initiated.
Gotcha. Okay. So, so you talked about some of the common diagnoses for what qualifies someone for hospice. Are there other ways besides the diagnosis itself that we can determine someone's ready for hospice?
Yeah, so I named the big ones, obviously, like Lou Gehrig's disease, and it could be Parkinson's, another neuromuscular problem, neurologic problem, cancers, dementias, HIV, liver cancer, lung disease, kidney disease, brain problems like strokes. But you could potentially have other things. So oftentimes somebody who's 93, who has a couple of spots on their lung and stops eating and is losing weight, they may not want a lot of testing. They may not want a biopsy to prove it is cancer, but they're losing weight, they're 93. And so sometimes we can put people on hospice without a firm diagnosis that it's a cancer or other things. So they're not eating, they're losing energy, their numbers are maybe abnormal on their blood work, their bone marrow function, their kidney, liver function. So sometimes we don't get a definitive diagnosis before we put them on hospice.
Sure.
Sometimes we just go by a set of symptoms, typically oftentimes appetite and weight loss, falls, weakness, sleepiness, tiredness, fatigability, easy to fatigue. Those are pretty common. It's a little harder to do to get them on hospital to get Medicare to see that, but it is absolutely doable.
Gotcha. Okay, that's helpful to know. Okay, so I want you to address some like common misconceptions, I think, from the outside. So like, is hospice voluntary? Like, does it always end in death? Can you have a DNR? Can you not have a DNR? Like, what are some of those things?
That's very good. And we should talk in a different day on euthanasia, because whenever people think of hospice, they think like somebody's giving up on me and they're gonna do me in.
Right.
And so we probably should separate that out. But hospice, once again, is an end of life. So it turns out Medicare requires two physicians to agree that it's usually your primary care doctor, your specialist, plus a hospice medical director to agree that you have less than 6 months to live from your heart disease or kidney disease or liver or cancer or whatever the diagnoses are. That's called the admitting hospice diagnosis or the primary diagnosis for hospice. And that's what they're coming into hospice for, so we can get money to cover their needs and to help pay for the team and their care, et cetera. So the patient has to voluntarily, if they're able to, if they have the cognitive abilities and they're conscious and all that stuff like that and are informed consent, either they enter hospice and they agree to no more curative measures and stuff like that, and they sign in for hospice, or their representative, their healthcare power of attorney, or there are a bunch of other ways to do this, but the typical healthcare power of attorney will sign them in if the patient is, had a bad stroke and is not waking up, or has a severe dementia and can't understand what we're offering. So the patient signs in for this. Once two doctors say, "Yep, you have less than 6 months to live." People do not have to have hospice. People can choose to not have hospice and also stop their general medical care or and stuff like that and pass away at home or at nursing facilities. Or they can decide to continue to have chemo or dialysis until the last day of their life.
Yeah.
So I want to make sure it's not automatic as soon as two doctors say that you have end of life, your life expectancy 6 months or less. Doesn't mean automatically you get on it or automatically. You could absolutely, we want people to be offered to understand what it's about, but absolutely not. It's not right for everybody. Some people, like my father, it was the last few days, there was a bunch of stuff to do in the last few days before he passed away that he got on hospice. He would not have been ready 6 months before that. He would not have been ready emotionally or otherwise.
Even though maybe his symptoms sort of qualified him for
Yes.
hospice. That's an interesting distinction.
Sometimes this, and I'll say this openly, sometimes our specialists, we're so good in the United States with specialist care. This is oncologists and cardiologists and kidney specialists. Sometimes we're so good that we don't know when to say enough. That we know that the cancer is metastatic and stuff, but we have one more chemotherapy, one more radiation, one more stuff, even though their numbers are looking worse in terms of their anemia, their kidney and liver, and their oxygenation, all that stuff like that. Maybe looking, but we have more stuff, more tests, and more things that we can offer. And so sometimes the patient, the family don't say enough, and sometimes the physician doesn't say is enough. Especially whenever you go to these super specialists, that you go to these universities where they get the most difficult of the most difficult cases. They're part of it. Their job is not to give up as early as community, physician or oncologist may say, not much more to do out here. Sure. So yeah.
That kind of dovetails beautifully into my next question, which is what are the goals of hospice care, and how are they different than the goals of any other type of care?
Well, sure. Well, certainly the goals of hospice care is comfort, and this is all levels of comfort. This is physical comfort, but it's usually oftentimes shortness of breath and pain are the two big ones that we deal with. Emotional discomfort. This is everything from sadness and grieving to depression to anxiety to spiritual unsettled. Heart accepting that this is happening, that it's them, that it's sooner than later, that their death may be coming sooner than later. So we use this, and this is part of the team, and we'll talk about the team and how we kind of interact with the family and the patient to help try to achieve that. Yeah.
And so the goal of this is non-curative stuff,
That's
right?
correct. That's right.
So,
it's not high tech. It's high touch, low tech.
Yeah.
And we can talk about that a little bit more. Sure. But yeah, it's not no more PET scans, no more CAT scans, no more calls to the ambulance to rush you to the emergency room. All that stuff that we oftentimes has been happening sometimes for years. We say. The patient, the family, the physicians are saying, we know that this is available to us, but we've chosen not to go that route anymore. But to be able to stay at home or a nursing facility or your independent living facility or wherever, and try to have a better quality of life without as much high tech.
Sure. And there is a relatively newer specialty in this space called palliative medicine, right?
Yeah. So.
maybe that's just
confusing.
semantics. Help me understand.
It is.
the
It is
role there.
confusing. The word palliation or palliate just means to relieve symptoms. You say, well, that's hospice.
Yeah.
Hospice is relieve symptoms, end of life,
Yeah.
the last 6 months.
Okay.
So
Okay.
palliative care can happen any time before, and
Yeah.
of course, it is part of hospice also. So, but the palliative care section, so palliative care consultation services that is offered by hospitals and other groups is somewhat different. Oftentimes these patients, oftentimes not always, are nursing home, long-term care nursing homes, and they're also at home. Those are typical palliative care.
Okay.
They may start in the hospital. You just had a stroke. You're not going to be terminal, but you can't swallow and all sorts of other things. But you're having some pain from your disability, from your stroke, and some other things, some depression. So sometimes palliative care is consulted after like a big stroke or other things. You're not terminal. You're not going to die in the next 6 months. Not near term terminal. So that's when sometimes an extra consultation. So oftentimes it's called the consultation service. They don't take over your whole care typically.
Yeah.
They help your other doctors kind of figure out the goals. You say, well, Chuck, that's what nurses and doctors have been doing for thousands of years, hopefully. The answer is somehow we made it into its own specialty, palliative care. So it's also for discomfort, whether it's pain, shortness of breath, all that stuff like that. But it's not end of life.
Gotcha. Okay, that's the distinction.
Right.
So, just so I can make sure I'm understanding clearly. So, like, someone with like Crohn's disease, for example, could have a palliative care specialist who could be involved in helping their symptoms, even if, say, they don't want to do more surgeries or they don't want to have an ostomy bag or something like that. They might work with a palliative care person to help come up with different options to relieve some symptoms.
Right. Don't understand the GI physician or the cardiologist, nephrologist all know how to do palliative care.
Okay.
It's just maybe not as coordinated as whenever you call a palliative care consultation service. A lot
They
of
might
times,
pull in different therapies or something. Okay.
So it seems backwards, but the quick answer is physicians, especially whenever there were not that many specialists around, had to do a lot of stuff.
Yeah.
And I'll talk physicians now, not nurse practitioners or other people who now also do some of the same things, obviously. But what's happened over the years is that physicians have gotten busier and busier, so that they're focused on treatment. Most of their patients are treatment, unless they're palliative care doctors or whatever. Most of their patients have got acute and chronic illnesses that are going to be their patients for decades.
Yeah.
So sometimes communication, slowing down and listening and communication is kind of lost. And so oftentimes that's what the palliative care consultation service physician or nurse practitioner will do is sit down and listen to the whole story, listen to the family, ask about the psychosocial aspects, all sorts of stuff that sometimes the regular primary care doctor or cardiologist or nephrologist or oncologist may not be able to slow down and do as well. Yeah. And so oftentimes the palliative care team will try to bring in together. Their best thing is to listen and to communicate between the specialists and stuff like that, and the family and the patient.
That makes sense.
Yeah.
But so hospice is inclusive of palliation.
That's right.
It's about comfort and
right.
soothing, which
That's
is
right.
the meaning of that word, right?
Yeah, that's right.
Okay, good. So do you before we go into what the team is comprised of, do you think or do you ever run into, like, as a hospice medical director, that the goals of like a patient's doctors are at odds with what your goals would be? Like if the patient is on hospice, like is there ever tension between those two groups of people?
Yes, of course. Like anything in life, it's just exacerberted because kind of the circumstances are heavier. Yeah, the consequences are bigger potentially. So absolutely. So anything that was happening before hospice is sometimes magnified. So if there was family tension about anything, about use of resources, use of time, how much money, is sometimes exacerbated once the person has a terminal diagnosis and people are having to kind of rearrange their lives to help this loved one.
For sure.
Whether it's their time or their energy or their money to help this loved one. So sometimes, ex-spouses, children that have been estranged, all sorts of stuff kind of comes to the surface whenever somebody's on hospice or potentially.
We're certainly going to get more into that.
Yeah, sure.
So when we were talking about this yesterday, you were helping me understand that hospice is about a team care approach.
That's right.
Can you talk about
Yeah.
who comprises the team, what their goals are, how often they meet, all that
Yeah.
kind of stuff.
Well, the team is fairly sizable, and they meet typically weekly or every other week. So Medicare requires that the team review all the patients on their service. Service means anywhere that the patient is, all the patients that are signed up on hospice, no matter where they are, every 2 weeks. So,
And again, whether they're at home or in a nursing home
correct.
or in the ICU. Okay. Yeah.
So typically during the pandemic, we did it virtually, but the rest of the world, rest of the time, we actually get together around a table, literally every week or every other week. Mine is on Wednesday mornings. It's been every other week for the last 3 years, and we're going to go to weekly coming up here. Half the patients from A till L, on one Wednesday, and then the rest of the last names
Yep.
on the next Wednesday. Anyway, so physician, this is the team that tends to meet or is available under Medicare guidelines. There's a physician, there's a nurse, an RN or LPN. There's a nurse aide. And there are sometimes included, not as often, physical therapists, occupational therapists, speech and language pathology specialists. So that's available. Sometimes they're oftentimes they're not there because they're not used that often. Social services, God bless the social workers and social services. Dietitians, we don't use as many dietitians, but dietitians can. Pastors, ministers and pastors. These are people that are hired by to be on the team. Those are the typical team members that are there. Once again, it's not just the team that this Medicare Part A, this is the hospital benefit, Medicare Part A for these patients that covers the expenses of all these professionals. But there's also volunteers. That's the next thing. And this Medicare Part A that pays for this hospice benefit also covers durable medical equipment like beds and bedside commodes and wheelchairs and canes, and it covers medications that are specific to the hospice diagnosis. There's one diagnosis. The patient may have 10 or 15 diagnoses, but there's one hospice diagnosis. So if it's the cancer from the liver that spread to the brain, then the hospice has to cover all the medications related to the treatment for the pain or anything that helps with constipation, all that stuff that relates to these things, and anything for seizures or any headaches. Hospice pays for all those things because Medicare tells hospice has to cover these things. Now the patient may still have asthma and emphysema and diabetes and neuropathy, but they're not related to the primary diagnosis, and so the patient can still get those medicines, but it's not under the hospice. They still can get it through the regular insurance or whatever insurance they're on. Yeah, that's right.
That makes sense. So, say a patient is going to be, newly admitted to hospice. Do their previous physicians follow them into care that way? How does the handoff of that work?
Yeah, so a large chunk of the primary care, usually the primary care physicians will follow their patients. Quote unquote follow means that they receive reports, they receive calls from nurses about symptom management, and they're the first ones to manage the medications and other needs for the patient, just as if they would, as whenever they were coming into the office as a primary care patient. So they kind of stand. But a lot of physicians choose not to, and they pass off the care, just like you said, hand off the care to a hospice medical director or co-director, et cetera. So now the hospice medical director, who is meeting weekly or every other week with the staff to talk about these patients, may know the patient fairly well because they get to hear about the patient practically weekly, and the primary care steps to the background and stuff like that. Occasionally, we'll have a specialist that'll be on board, like a nephrologist or everything. But person on dialysis comes off dialysis, they're not going to get a kidney transplant, et cetera, and they come on hospice. Occasionally, we'll get a nephrologist or so, a cardiologist on board, but typically not. It's typically either primary care doctor with a hospice medical director as a backup physician for orders, et cetera, symptom management, or just the hospice medical director.
Sure. Is there ever tension,
Sure.
in mediating that kind of dynamic between two physicians? Maybe there's a
Right.
long time primary care physician
That's
who's
right.
been taking care of someone for 40 years or something, and they have a lot of opinions about how their hospice care should go.
Yes.
Does that happen frequently? Or
No, fortunately, it does not. A lot of primary care physicians will say, "I'll take care of the patient, but you manage the new morphine and the
Okay.
fentanyl and stuff like that, the shortness of breath,
Gotcha.
because you have the nurses there to listen. And I'll manage their diabetes and other
Right.
things. So that's one way of doing it. The other way is that the docs oftentimes will know each other, but sometimes you just pick up the phone. It's professional courtesy to pick up the phone. If you disagree, if the primary care physician or whomever is the nurse is calling saying the patient's short of breath and they decide to use this medicine or to decide not to do anything, the nurse could call the medical director and says, I'm still worried about blah, blah, blah. And for the medical director to pick up the phone and call the other physician and see what their thought process is and say, the nurse has been out there. I went out there myself to take a look at the patient. I think it's wiser to do this. So some people will take offense, but it should not be offensive.
Certainly part of the professional
That's right.
plan already of how to navigate that.
Yep.
That's great. Okay. So now that we kind of have a handle on what hospice care is and how it functions for patients and the team members that comprise the hospice team, let's talk more about the personal and family dynamics that come into play.
Sure, yeah.
When someone is considering or is going to be admitted into hospice. So my first question for you is, in your experience, do most patients and families know what to expect from hospice care? You just listed off some of that stuff about like the different people who are involved, the durable medical equipment, the meds that are covered for the specific diagnosis. But
Yes.
other than that, do you feel like there's a lot of education that's needed?
Yeah, it's a ton. Now, some people come on board because they've had a loved one. They themselves have been on hospice and got better and were discharged from hospice. We could talk about that. Or they have had a loved one on hospice and they were very involved with that loved one's care until they passed away. So a lot of people are out there that do know quite a bit about hospice because of personal experience. But by the same token, just like you mentioned, and what we have in front of us are a couple of pamphlets that we hand out to patients' families to describe to them symptoms, what to expect as people their demise, their physical symptoms get worse, or as their systems shut down, their body's homeostatic systems shut down
As they approach death.
Yep.
Yeah. Okay. And we're certainly going to talk more about that. Is there and maybe the social worker is a person involved in this, but
Sure.
like you were talking about how, not everything is covered under hospice and that you kind of have to navigate the difference between regular insurance and hospice and that
Yes.
there's limitations to the per diem and all that kind of stuff.
Right.
Who helps patients and their families understand what hospice does versus what they need to find somewhere else?
So everybody in the hospice team will have some understanding, but the people that kind of know it the best include the nurse, the nurse who's at the bedside, and the social worker. And there are people that oftentimes are not at the bedside. There's business people in the business office that will sometimes know some stuff that the clinical people don't know. And there's managers over the nurses that may know. And in my current hospice company, and I'm not speaking for them, I'm just speaking for myself, we have a national company that oversees everything we do. So there's multiple layers of people that are in the know about coding. Coding is what the numbers and letters you write down for Medicare, so the patient can continue in hospice, et cetera, et cetera. Yeah.
Okay, so that coordination of benefits kind of gets worked out between
That's right.
many different people with different roles. Okay, that makes sense.
It tends to be less work for when you go on hospice. You tend to have those ABNs, those advanced beneficiary notices, and all these things that you get in the mail whenever you go see a physician or go get a lab drawn. You'll sometimes get stuff for months afterwards in terms of notice of what your insurance does cover, doesn't cover. Oftentimes, it's much less for hospice.
Gotcha.
Yeah.
Okay. All right. So, we kind of alluded to this previously, or you did that, patients and their families sometimes have conflict during this time.
Yes.
So, can you talk a little bit more about that? What are some of the kinds of conflicts that you see? Disagreement about care, how much to spend on it, when and where to have it?
Well, the very basics is if a family member doesn't think somebody should be on hospice or should be on hospice. So there are relatives that have opinions, and loved ones have opinions, and friends sometimes or that have opinions of whether somebody should be on hospice or not on hospice, or should be on this hospice versus another hospice. So in St. Louis, we may have upwards of 30 of hospices to pick from.
Wow.
Yeah. And hospices typically have to cover an area like something like 1 hour by driving distance away from their central office, so they can cover, they could cover maybe 50-mile radius from their central office according to Medicare guidelines. So it's a pretty extensive area that you potentially cover, but we fortunately have many choices here in St. Louis.
Can I ask
sure.
just a little clarifying question about that? Since hospice is a Medicare benefit, does Medicare have to equally cover all types of hospices? Are there cash-only hospices? Are they
That's a good
that
question.
provide different levels of care?
Yeah, no, I won't know fully. I could always ask because that's an interesting question. Because certainly with primary care, you can go see a boutique doctor that may just take cash and not take insurance. There's probably no such thing in hospice. All hospices are primarily paid through insurance, and oftentimes it's Medicare. Probably 90%, 95%. 98% of the time is probably Medicare that pays for hospice benefits. Other insurances will have, obviously they have to have hospice benefits obviously also. But that's an important aspect of it. Now, what's not covered is, and I'm not sure if we're going to talk about this later. What's not covered is private duty nursing,
Right?
And paying family members to come in and sit with their relative and other things like that. So what's not covered is room and boards for hospice houses. That comes out of your own pocket, typically. So hospice covers the team taking care of you. Hospice durable medical equipment like and oxygen. They cover medications that are specific to your primary hospice diagnosis. And so that's where kind of Medicare stops paying is this level. So if you needed somebody to watch you 24 hours a day, and because other people in your household had to go to work or had babies or anything like that, you pay out of pocket for extra people to watch you and stuff like that. Private duty nursing.
Sure.
So yeah.
Okay.
So yeah, typically I don't think I've never heard of a hospice that is just a straight cash place, and that gives you a different level of service.
Sure. Okay. Okay, so what about just previously existing family strife and issues? Do you see that come out?
Absolutely. If we have everything, we're a microcosm of what's happening in society.
Sure.
There are people out there that have had drinking problems that whether the patient or their family members, they've had financial problems. They've been abused or been abusers themselves. They have problems about getting their house is going to be repossessed or their car. So everything out there that happens in the regular world is happening to our patients and their relatives. So that's where our nurse and our social workers and our ministers, kind of who are oftentimes at the bedside, speak to us about these things. So if a loved one needs a Family Medical Leave Act in order to stay home and help take care of their dying loved one, we're the ones that help write that up for their family member to take to their HR department and stuff like that. But that's correct. We sometimes have to kind of mediate as best as we can about these conflicts. And oftentimes we'll sometimes tap the physician, or the medical director, or tap the primary care doctor, whomever that's known them the best. We have patients from the VA, the Veterans Administration. They're veterans from military conflicts that are in our program, et cetera. So we have multiple things that we have to deal with that we've gotten pretty good at doing and understanding how much we can do and what probably we can't do or shouldn't have to do. Yeah.
What about secondary gains? Do people try to take advantage of hospice patients? Like, how does your team look out for that?
Yeah, so the secondary gains means that somebody has an ulterior motive rather than our primary motive to take care of a patient, emotional, physical, and spiritual. So if a relative thinks that they're going to come into some money after this person dies that's on our hospice program, and they're complaining that we're not treating their pain enough and we need to give more pain medicine and stuff like that. So there are occasional cases like that. We have So we have to become aware of that, and it's a challenge. There's no doubt. These are not just because we can name it or recognize it doesn't mean it goes away.
Sure.
We have patients where because we put a lot of controlled substances in the house, benzodiazepines like Ativan and narcotics like fentanyl and morphine, and we have to. So sometimes. Liquid and pill medicines go missing or are used too, quote unquote, used too quickly. And sometimes our worry is that not the patient's not maybe taking extra without telling us, but their grandson or the grandson's friend that comes to visit and stuff like that is grabbing and running off with these products. So we have, once again, we're a microcosm of the real world.
Yeah, absolutely. Okay, so what about ethical concerns? So, DNRs, power of attorney, voluntary care. Like, what if a patient changes their mind about receiving care, but they're too, doped up basically to express it? Like, how do you manage those things?
So, competency from a medical standpoint, not a legal standpoint, but from a medical standpoint of competency, if the patient is able to understand what we're saying when we explain hospice benefit to them before we bring them on board, there's an admission nurse that comes and sees looks at their history and sees just because somebody asks. And by the way, that's a good question, but you haven't asked yet. Who can refer a patient to hospice? A patient can self-refer to hospice. Their loved ones or relatives, a physician, a nurse, practically anybody can refer to ask us to come look at the patient and then their medical record for hospice.
Right.
That's correct. So that's the first thing. The next thing, like I said before, if the patient is competent, and once again, it's sometimes tricky, just like you said, they've had seizures, they have a brain tumor, they're demented, they're in great pain. How competent are they to listen to a description of not going to the hospital and staying at home or a nursing facility and not calling 911 while we try to take care of their symptoms? So that's another challenge that we sometimes run into is like, was the patient well informed? Were they coerced in any way by their relative, et cetera? Right. So that's the next thing. Then the do not resuscitate DNRs. Because I can't remember acronyms and stuff
do
like
not
that.
resuscitate.
So I'll just say the words do not resuscitate means that you've pre-written. It's a single sheet. You could have an outpatient do not resuscitate or in hospital or out of hospital do not resuscitate sheet that says I don't want a CPR or I do want CPR, cardiopulmonary resuscitation. If I stop breathing and my heart stops, pump on my chest and put me and blow in my mouth and put me on a ventilator and use medications to keep me alive. So that's the resuscitation that we would typically talk about. I don't want IV fluids. I don't want dialysis. So all these things you check off, it means do not resuscitate at different levels. It's not just one type of do not resuscitate. Right. So that's the first thing. You can have a do not resuscitate. That tells us that, if you have a do not resuscitate paper signed and there's informed consent without coercion, that is enormous help for us to understand. Nobody has to call 911, et cetera, et cetera. So that's the first thing. Now we have a small handful of people that don't want to sign that but still want hospice. You say, oh my gosh, that's terrible. But we can help give people comfort before 911 is called. So that's a part of it, is to say, hey, we're going to help you with your lung cancer, symptoms of shortness of breath and stuff like that. But they have not signed a do not resuscitate. That means they want to be resuscitated. So now that they get a pneumonia, now they get short of breath and they get confused. Now you have to call 911 because they're going to potentially die. They're going to potentially stop breathing because of the pneumonia on top of their lung cancer. So that's when they do call 911 and they go to the hospital and they come off of hospice while they're in the hospital because the hospital is doing resuscitative stuff. That's not just not just comfort.
So if someone signs a do not resuscitate order and then in the moment when they can't breathe, they say call 911, does the document supersede what they want in the moment?
No, that's a good question. That's where a lot of conflict comes up. That's where attorneys and stuff, but once again, we're in an acute situation. We can't call a judge. We can't call an ethics committee.
Yeah.
So
to make an in the moment decision.
That's right. So for emergency decisions, that's right. For emergency decisions like that, oftentimes we'll side on the treatment, calling 911 or go to the emergency room or the treatment, and then we can later say, well, I thought you wanted this. You said this, and you written this, and you told other people this, but you changed your mind at the last minute. And by the way, nobody should ever feel guilty that they changed their mind. Yeah. Whether to get on hospice, not come off of hospice, go to the to the ER, not go to the ER. We tell you what our hospice purposes is to avoid the emergency room, avoid all these things. We try to keep you comfortable at home, oftentimes with morphine and people around you and oxygen and other medications, Ativan and other things. It's not the same as going to the hospital where they may put you on a breathing machine and they may give you antibiotics and other things like that. So that's the kind of the balancing act. And this is the kind of the ongoing negotiation with any patient or any family who's speaking for the patient. Our power of attorney is what's our purpose, what's our goal. They have a pneumonia, but they've been curled up in bed with dementia and shriveled up for 3 years. If we treat the pneumonia, and they're just going to end up in the same bed
for even longer. Is that right?
Right. Or, well, the pneumonia is the way natural course of most patients with dementia don't die with the dementia.
Right.
They die of some complications.
Else.
Urinary tract infection, pneumonia, other things like that. So this is the challenge. This is the hard part about anything, whether you're on hospice or not, is end of life decisions and who makes them and how well do they stick. Were people in the right mind, when they're thinking about their best interest, or other people who speak for you, healthcare power of attorneys, are they thinking about you and your best interest? Yeah.
So which of the hospice care team members are often involved in helping navigate some of those situations and decisions? Probably the nurses are probably the frontline people dealing with it, right?
The nurses and the social workers will see it most clearly in first. They're oftentimes at the bedside, in the room, meet the family, etc. So the family dynamics are very important, especially if a family member is not in town, not in the state, and they're trying to try to figure out things remotely, especially if they're people local and people far away. The local people see things differently than what the people far away are seeing or hearing. So all these things are levels of challenges that are there with or without hospice, but they're certainly magnified when you feel like you have to make urgent decisions about care.
So probably social workers and pastors
That's
and
right.
all those people are part of that emotional and mental support that
That's
hospice
correct.
is offering, both to the patient and to the family, right?
That's
to
right.
try and mitigate some of these conflicts and.
Oftentimes the patient is the easy part. It's sometimes
It's
because
the
the
family,
patient,
sure.
The patient is the sick one. The patient is just happy to be taken care of. The patient stuff like. But unfortunately, there's not everybody sees everything. And sometimes the nurses or the physicians are pretty rigid themselves because they've been longstanding and they kind of know what's good for the person. But we have to be careful about that part. But that paternalistic attitude that I know best for you because I've done this for so many years. I've taken care of a lot more people than you've seen die. I've taken care of a lot of people. So you got to be very, very, very careful about cultural differences, historical differences. Like me, both my parents didn't. They were not alive to know this, but I don't think they had as great care. This is 30 years ago. Had great care with hospice back then as what I think we've been able to provide, stuff like that. So there's a lot of history back there, cultural and personal.
That's my next question. Do you see cultural differences in people and families and how they want all of this handled? Can you give some examples?
Yeah, sure. Well, certainly within certain religious. So, in the African American community, for instance, talking about cremation is probably oftentimes a big no-no and stuff like that. So that some people are insulted that you bring that up.
Wow. Yeah.
Just to talk to people about options or to think ahead about what nursing home would you like to use to transport your body from the nursing home or from home? And some people are insulted that you bring that up, even though they're on hospice.
Right.
So our purpose is not to push, but to ask the appropriate questions. And some people say, you never asked me that. You never told me. Oftentimes we did, but people don't remember. They don't understand. Everybody's under stress. And sometimes we do forget to do things. But that's why we have handouts. Almost every hospice has a folder that the patient keeps at home that they can take with them if they still want to go see the physician. On hospice, you can still go see your physician. Most patients don't. They're very, but some people literally on hospice are still taking trips, are still going to the grandkids' graduations and weddings. Yeah. So not everybody's curled up in bed waiting to die.
Sure.
So there's a big range. But yes, there are a lot of differences, and the cultures is not just ethnic cultures, but within your family, within your spiritual faith. Sure. So we have to be sensitive to all these things. We have our pastors are oftentimes Christian, Protestant, typically, and some people are insulted that if they're Catholic or if they're Jewish, stuff like that. Most people are super. Most patients and loved ones are super nice. Say, we love you. you, please come.
Yeah,
or no,
right.
thank you. We have our own pastor,
Yeah.
our rabbi, whatever. And that's wonderful. I think that's excellent. Yeah.
But there, you would say there's certainly a great amount of deference given to the patients themselves and with their families' wishes.
Yes.
And you guys do a lot of work
Absolutely.
to be respectful.
Absolutely.
empower.
That should be a large part of what we do. It's easy to manipulate the milligrams of morphine and how many nebulizers for your duonebs for your breathing and manipulate your Lasix. That's very easy. The hard part is understanding when people are under duress and under stress and spiritual stress, emotional, physical stress, how to work with them and how to not to step on people's toes and to try, still be there for them, no matter what the hardships are.
Yeah, absolutely. It hearing you say that strikes, it just makes me think that your decades of experience as an intern has probably prepared you really well to deal with a lot of these situations and balance those two things.
There are no 23-year-olds that sit around the table.
Yeah.
It's very hard to get a person. Not that 23-year-olds. Some 23-year-olds have seen everything. But to have a young doctor or a young nurse or a young social worker or a young pastor is pretty rare.
Yeah.
It's pretty rare because the experience comes with years
Yes,
of living.
Yeah, absolutely. So, kind of to close us out here, in your experience, then what are the best ways to prepare patients and their families for the actual experience of death and dying?
Yeah. So we do this as booklets, and I'm looking at one of the booklets that we hand out, and I think that's extremely important because it doesn't use jargon. It's big letters for people with poor eyesight like me that still have poor eyesight despite my reading glasses. And it talks about kind of starting from a few months before to last few hours.
Yeah.
And so let's go over some of this stuff.
We're gonna actually, in our second part here, we're gonna go into this completely.
Beautiful.
Yeah. So certainly providing information and having open lines
right.
of communication
That's right.
are certainly how to set
and not use weird lingo
Yeah.
and jargon, and to mimic or mirror what the patient or their loved ones, how they use the terminology.
Yeah.
For us to use their terminology instead of
Sure.
them. I'll sometimes tell people this is the terms that we use,
Yeah.
but let's use your terms
Right.
because now I know what you mean.
Right.
So that way they
Speak
understand
their language. Wow,
Right.
that's a very loving
it's
gesture.
I just want them to know that sometimes other people will not notice that we're speaking past each
Yeah.
other, and that I recognized it, and I want to make sure that they understand, all sorts of DNR, do not resuscitate.
Right.
There are multiple ways of quote unquote not resuscitating. So so all these nuances that you think, well, surely people understand or know. The answer is they don't,
Yeah, absolutely.
and they're well educated too, but they don't.
Sure. Okay, so this has been super informative, all about hospice,
Yeah.
kind of the services that are provided, what to expect when loved ones put on it. So this is the first part of our discussion. The next part, we're going to talk more specifically, actually through one of these booklets that's given to hospice patients about what to expect from the dying process itself, those
Yes.
last, months, days, and moments of a person's life, the physical, mental, and emotional changes that are experienced. So
Yes.
please hang on tight with us, audience, and join us for the second part. Once again, this is the Not Your Doc podcast. You can check us out on YouTube, Spotify, at our website, notyourdoc.com. You can email us, of course, at notyourdocpod@gmail.com. And we'll be back for part 2. Thanks, Dr. Tadros.
Thank you. This previous podcast represents my opinions and the opinions of my guests. This is not medical advice, and I'm not establishing a physician-patient relationship with any listener. The content here should not be taken as medical advice. The content here is for informational purposes only, and because each patient is so unique, please consult your healthcare professional for any medical questions that you may have.